Imagine it's Friday, and a 50-year-old white woman is anxiously sitting in a surgeon's office with her stoic husband. She had her very first colonoscopy a week ago, and the endoscopist told her he found a mass that looked like cancer, and in the meantime, he would send her to a surgeon to take it out. Drinking the bowel prep to get cleaned out wasn't even that bad. And she was told that would be the worst part. She's on pins and needles. Meanwhile, her husband's sitting there watching the latest election hoopla on the office television. But she can't even bring herself to look up or pick up the Better Homes and Gardens beside her. I mean, she doesn't even know if she has cancer or not. She called her primary care physician, but he didn't know the results of her scope, or even that she's waiting to see this surgeon. He asked, was a biopsy done, or was the tumor marked in any way? She thinks so. She said the endoscopist told her the results would be back in a few days, but she doesn't know if the results are back yet or not. She thinks to herself, am I in the right place? Am I seeing the right surgeon? Will I get the best care? Should I have taken my junkyard dog of a sister with me to this appointment instead of my reserved husband over here? So what's right and wrong about this picture? First off, she's 50 and white, and if she's average risk for colorectal cancer, meaning no family history or any other risk factors for colorectal cancer, then she's right on time to be screened with a colonoscopy. If she were African American, some experts would say she needs to start screening at age 45. But for this lady, A, she had the guts enough to schedule the procedure, B, take the bowel prep, which is not that bad, and C, complete the procedure. And it also tells us a little something about her PCP, or primary care physician. He did his job to make sure that she was screened and at the appropriate time. And you can tell that they have a good enough doctor-patient relationship that she feels comfortable enough to give him a call, which is critical in this day and age that we live in. It really is. Second, let's examine the timing from colonoscopy. It's been a week, and she's already in a surgeon's office. It's pretty expedient. But there's a communication gap that exists between the endoscopist and her, as well as the endoscopist and her primary care physician. So providers have to set better expectations for patients. The endoscopist should have informed her when exactly the pathology results would be back from her biopsy, or the off chance that they may not be back in time before she sees the surgeon. Also, he could have communicated to her of what potentially is next. Would she need more testing like a CAT scan? Or would there be more referrals needed like a medical cancer doctor or the oncologist? And also, he could have communicated to the primary care physician the results of the scope. But we've entered an era in our health system, in health community, of this indirect or passive communication, where we rely very heavily on electronic medical record systems, as well as message boards, which are great when implemented and set up properly, but every now and again, there's a glitch in the matrix. Regardless, the responsibility to provide the best care and best recommendations still exist. And I know it's a fine line, because Care providers take care of a multitude of patients and don't have all day to spend with one patient going over the same questions over and over and over again either. I overheard a surgeon the other day say a bit of medical knowledge can be problematic. As he walked out of one of his patients' preoperative exam rooms. And I could only envision that the patient and the patient's family were probably asking a bit of the same question that they were asking in the office, and maybe with a bit more knowledge, either from a friend or from the internet. Remember Y2K? What was that all about, really? We get some of the best and worst things, as we all know, from the internet. But for this patient here, I can only imagine the vulnerability of being a surgical patient. So as providers, we must indulge, because patients are asking questions out of apprehension or just for an attempt at clarity. And I'm sure this provider did that. We have to gently reassure and or redirect the patient as needed. Some of the solutions to this that I have used and that I've seen work are: one, provide your patients with your practice's summary and management of the disease process, in this case, colorectal cancer. And more importantly, go over that information with them to make sure they understand it. Two is to provide external source material from websites that you approve of, like WebMD or cancer.org. And lastly is to spend those extra couple minutes with the patient to simplify the game plan of care. So back to our patient. What about the questions she's beginning to ask herself? They're pretty reasonable, right? My parents would always tell me, "You have not because you ask not." Well, can I have a dog? Can I get a car? I'm from Boston. Can I get a car? Hey, I took a shot. Patients should do the same thing. And I know some patients don't know to ask, and some patients don't know how to ask. Try, "Why, doc?" Or simply, "I don't get it." Everyone remembers Tom Hanks and Robert Loggia on this huge toy piano in the movie Big, playing chopsticks. In this movie, he plays a little boy that wants to be bigger. His wish comes true, and as a grown-up, he lands a job at a corporate job at a toy company. And one of the critical or funny scenes in the movie is he's at a board meeting and he says to the antagonist, "I don't get it." And everyone stops and his concerns are addressed. Patients should do the same thing. Ask. Do that good old-fashioned internet research on your doctor's approved websites. And lean on knowledgeable friends and family for help. Ask every step of the way. Don't take a chance on your well-being. We all remember Monopoly, right? We don't want to be taking a chance. Would you take a chance with your best friend or your family member's well-being? No, none of us would. And so that's why it's very important to have that backing and have that patient advocate by your side. So it's good to have that junkyard dog of a sister there with you. with pen and pad in hand or tablet in hand, jotting everything down and asking some of the tough questions. But I think it's better for everyone if she doesn't look or act like this. This is more like it. And as you see, I've been watching a lot of Tom Hanks recently. So does it matter what hospital you go to for the treatment of colorectal cancer? Let's review some of the data. I mean, the data suggests that the answer likely is yes. I wish this picture was in color, but it wasn't. In 2006, Rogers and colleagues, they took a look at this. And they used the California Cancer Registry, which consists of almost 30,000 patients with colorectal cancer who've been treated, and they saw that busier hospitals and busier surgeons in the lighter shade had better survival. For some reason this pointer's not, doesn't really work that well here, but it's all good. They had better survival. But they didn't look at specialty. So the question is a colorectal specialist or colorectal surgeon better off treating colorectal cancer than a general surgeon is? So, I'm not really a Duke fan, but I had to put this on here. The study of the colorectal surgeons at Duke, they performed a study where they looked at their hospital, which is an NCI hospital, or National Cancer Institute designated cancer center, to answer this question of whether for colon cancer, who's treating those patients better, how are the outcomes? Are the outcomes better for colorectal specialists? And they found that specialty was an independent predictor of better outcomes. So that's at one center. What about nationally? So I trained and did my colorectal fellowship at the University of Pennsylvania, and a couple of the studies that I completed and was a part of and that were published a little bit earlier this year looked from a national standpoint with comparing general surgeons to colorectal specialists and looked at outcomes as far as survival goes. And we found that for stage 2 rectal cancer, there is a difference in that colorectal specialists do have better outcomes. And just to review the stages, stage 1 is when the tumor or cancer is in the wall of the colon. Stage 2 it's still in the wall of the colon, but it's almost breaking free and out and through the wall of the colon. Stage 3 is when it's gone out into the lymph nodes. That's the first place cancer spreads before it goes to other organs of our body. And then stage 4 is when it goes to organs like the liver or the lungs. And a lot of experts feel that stage 2 is the most important stage, where surgical technique as well as collaborative thinking with the multidisciplinary team of the surgeon, the primary care physician, and the oncologist take effect. The other study that I worked on with my colleagues at the University of Pennsylvania had to do with the number of lymph nodes that are taken from the resection that the surgeon completes. And why is that important? Well, in 2001, the National Cancer Institute, or NCI, they got a panel of experts together and determined that in each resection specimen, you need to have at least 12 lymph nodes in order to definitively state that you confirm the absence of lymph node spread. And so we said, okay, is there any difference? And we found that for colon and rectal cancer, there is. Colorectal specialists are about 1.5 times more likely to get that minimum of 12 lymph nodes for colon cancer and rectal cancer versus general surgeons. So to sum everything up, we see that patients need to realize that they have the power to ask questions. And sometimes they need to conjure up that strength for themselves, just like we would for any one of our best friends or family members. And on the other hand, care providers and physicians have the responsibility to answer those questions as part of getting those patients to the right place for the best care. Thank you.